A baby having bilateral congenital clubfoot. The deformities are equinus at ankle, heels are in varus, feet are in supination and abduction. There is some cavus also. The feet are manipulated for 1 to 2 minutes before applying to the plaster cast. Cavus is produced by pronation of the forefoot in comparison to the hind foot, which is in supination. The cavus is corrected by supinating the forefoot. The foot adduction is corrected by abducting the forefoot in supination, and counter pressure is applied over the lateral aspects of the head of the talus. In the same manner, both the feet are manipulated. A thin cotton roll is applied tightly over the foot and lightly over the joints. The correction is maintained while cotton is applied. The toes of the foot are held with the thumb and index finger of one hand, and the thumb of the other hand is placed over the lateral part of the head of talus. The middle and index fingers should be kept behind lateral malleolus in such a way that the tip of the middle and index finger reach over the medial malleolus of the foot. The cotton roll is extended up to the upper third of thigh. Now a plaster bandage is applied over my fingers to prevent the crowding of the toes. Care should be taken that the plaster bandage overlaps about half of its width in each turn and should start from toes proceeding upward up to the upper third of the thigh. While plaster is applied, a light counter pressure is maintained by the thumb over the lateral part of the head of the talus. To prevent sores, care should be taken that the thumb is not placed at some place for a longer period. The forefoot is gently supinated, keeping the foot in position of a bit of abduction. The plaster is well molded over the heel in such a way that heel can be made out easily. The supination of the forefoot should be visible in a well molded plaster cast. The cast is extended up to the upper thigh, keeping the knee in 90 degree of flexion. Wrinkling in plaster bandage should be avoided to prevent constriction bands and pressure sores. The plaster is well molded in popliteal fossa to prevent pressure over vessels and nerves. The plaster should be thicker over the dorsum of the knee joint. The correction should be maintained till the plaster sets. In the similar way, plaster cast is applied on the right foot. The first cast maintains the foot in supination and equinus. Seven days later, the casts are removed and the feet are manipulated again and new plaster casts are applied. The forefoot is in supination and is abducted to the neutral position. Care is taken not to pronate the foot. The correction is maintained while cast is applied to the foot. The foot and heels are well molded. The toes are held by the thumb and index finger of one hand, and thumb of the other hand is placed over the lateral part of head of talus. And minimum of adduction. 7 days later, casts are removed and feet are manipulated again. A new third plaster is applied. Gradually, the foot is abducted. Seven days later, casts are removed and feet are manipulated. Fourth plaster cast is applied. Gradual abduction about 30 to 40 degrees achieved. In a similar way, fifth cast is applied and 70 degree of abduction is achieved. Percutaneous sternotomy is performed to correct the residual equinus deformity at ankle joint. The criteria for this is abduction of 70 degree and dorsiflexion of 0 to 5 degree. A local anesthetic, that is xylocaine 2% is injected about 2 cm above the insertion of tendoachilles, and a bit of massage is done to reduce the swelling due to the anesthetic agent. Now, number 15 blade is inserted on the anterior aspect of tendoachilles after palpating it at 90 degree angle. The tendon is cut percutaneously with a pop sound. Care is taken to avoid the cutting of skin, otherwise mesotendon will be cut. A gap is felt over the tendon and the foot is dorsiflexed 20 degree to achieve dorsiflexion of 20 degree. In the similar way, tenotomy and the other foot is performed, and here also 20 degree of dorsiflexion is achieved. Dressing is done to check bleeding. plaster cast is applied in 20 degree of dorsiflexion and 70 degree of abduction. Percutaneous sternotomy is being demonstrated in a fresh cadaver. Number 15 blade is inserted 2 cm above the insertion of tendoachilles from the anterior side and the blade is rotated 90 degree. The tendon is cut. Precaution is taken to avoid cutting of skin. The major tendon of posterior and a bit of medial and lateral side remains intact as has been shown. The tendon generates in the remaining major tendon. 3 weeks later, plaster cast are removed and foot abduction brace is given to the child. The orthosis is worn for 23 hours for first 3 months and then at night time only till the age of 3 years. The length of the abduction bar is equal to the width of the shoulder of the child. The foot is maintained in 70 degree abduction on affected side and 45 degree abduction on the neutral side with 20 degree of dorsiflexion on both sides.